Just come up here and
Yeah,
we
thank
can,
you.
I'm very anxious to hear more about your research and have you share that with our group. So
Thank you. Thank you very much. I'm really delighted to be here, and thanks to April for the invitation to come and share some thoughts with you all. So I'm what we call a physician scientist across the street, and that means I'm a part-time physician and a part-time scientist, which means I'm not very good at either. And I see patients in clinic. I'm an endocrinologist and see a fair bit of diabetes, and so this is one of these kind of situations that I obsess about over time. So this is a patient of mine, PW, who I first met in 2005. At the time, he's in the military. He's an advanced weapons specialist, a very, very high-functioning, very intelligent, very successful person who developed type 1 diabetes. And you can see here, I'm showing his hemoglobin A1C. So when I first meet him, he has a hemoglobin A1C of 10%. This is newly diagnosed, very uncontrolled diabetes. And he meets at that point in time what I'd like to think is an exceptionally talented endocrinologist who gets his hemoglobin A1C rapidly down to 5.5. And so we're very proud of ourselves. We have really great medications, very good insulin. I have very good nurses and diabetes educators and nurse practitioners, and we really hit him over the head with his diabetes and his diabetes care, and he does a great job. And then, unfortunately, life takes over, and this is the natural history of many of our patients with diabetes, and this is the frustration of many of us who treat diabetes, that we see this sort of a pattern. So you see he achieves really great glycemic control, and then his hemoglobin A1C drifts up over time. And what else happens to him? So, of course, when we start to insulinize him and he gets good glycemic control, and then he adopts our Western lifestyle, he gets discharged from the military because of his diabetes, now his weight begins to creep back up. He has a number of other experiences along the way, suffers from pretty profound depression and sleep disturbances that happen, ultimately has some difficulties with substance abuse, and then some difficulties with the criminal justice system, and finally makes it back to school to get retrained in another area that he's interested in, and really struggles and has cognitive issues, cognitive problems. So for me, this guy who showed up really is one of the highest functioning, successful people I had seen at the time his diabetes was diagnosed. Then moving across this whole spectrum of his diabetes care and through a number of these mental health disorders is one of these things I obsess about. I have so many patients like this, and we can't figure it out. So this is the epidemiology of my clinic, and this is the extent of my epidemiology expertise. I have a small number of people who get really good diabetes control with little effort from me and little effort from my staff. Have quite a few people who do okay, to get pretty modest blood sugar control, but it takes a lot of effort on my part. It takes a lot of effort on my nurses and diabetes educators and the whole team. Really working very, very hard to support these people and have them achieve decent glycemic control. And then we have a lot of people like this, a lot of people like PW. Very, very poor control, despite having, fortunately in my practice at the VA, we have a lot of resources. I have the ability to spend a lot of time. I have a lot of support staff and a ton of resources. And despite having all of these resources, we have so many people who just simply cannot take care of chronic disease, who cannot grasp and manage and self-manage chronic diseases like diabetes, like obesity, like a number of other problems. So when I think about diabetes and I think about the problems that a lot of these people have, certainly folks who have been in good glycemic control for some period of time who come to me now with terrible control, the first 4 or 5 items on the differential diagnosis are depression and depression and depression and depression. Diabetes care, diabetes self-care is a very numerical game. It's not brain surgery, to be honest. If we can do modest levels of mathematics and have some decent numeracy, people can do really well with diabetes. And so cognitive issues tend to be a big problem. Certainly weight gain and obesity, and then addiction is quite common in our VA population as well. And so these, I think, all come together, and what I've been obsessing about is what is the biological basis of this? Is there really a shared mechanism upstream of this? Is there some shared upstream common pathway that becomes manifest somewhat differently in different people over time. And I think that this is really related to overnutrition and inflammation largely in the central nervous system. And so we'll talk about that. But before I talk too much about that, we need to ask this question. And you could ask this question in a lot of different ways. Is body weight regulated? Is blood sugar regulated? Is mood regulated? Because I think coming from a physiological perspective, I was trained as a physiologist, and we think about biofeedback and regulatory mechanisms. And if we can really understand how the normal regulation works, then we can begin to understand how pathology or dysfunction in these regulatory systems occurs. So this is one of my favorite slides to talk about body weight regulation. This is a really classic experiment that was done a number of years ago called the Experimental Obesity in Man Studies. The other name that's given to this is the Vermont Prisoner Studies. And the reason for that is that they took a group of volunteers in the Vermont correctional system, and they actually motivated these people to overeat. And what they basically did was they opened a cafeteria up in the prison that had any kind of food anybody could possibly want to eat, and they paid them cash to overeat. So you can see here, this particular individual in the run-in period of this study is weighing 75 kilos. He's in neutral energy balance. He's not gaining weight. He's not losing weight in this run-in period. And he's in neutral energy balance, consuming about 1,500 kilocalories per meter squared. So this is a key concept in energy homeostasis. When the number of calories consumed are equal to the number of calories burned, somebody remains weight stable, and this is called neutral energy balance. This particular person was pretty motivated by cash, you can see. And when the intervention started, he doubled and tripled and at one point almost quadrupled his caloric intake to 6,000 kilocalories per meter squared. On average here, about 3,000 kilocalories per meter squared, doubled his intake. So what happens when a person goes into positive energy balance? There's no mystery or surprise here. Weight gain ensues, and he tops out about 95 kilos. Now, if you look at the top part of this curve and just kind of squint and envision this as a flat line, right? So he's now neither gaining weight nor losing weight. This is what form of energy balance? Positive, negative, neutral. Neutral energy balance, right? He's in neutral energy balance here, but he's in neutral energy balance while consuming 3,000 kilocalories per meter squared. So what you can infer from this is that one of the regulatory adaptations to positive energy balance is an increase in energy expenditure. We can be quite certain that his basal metabolic rate, that his energy expenditure has gone up from 1,500 kilocalories per meter squared to 3,000 kilocalories per meter squared here. One of the important components of the regulation of energy balance is regulation of energy expenditure. The other thing that happens then in this study is that at some point in time, they stop motivating these people to overeat. That happened right about here. And then you can see the second major component to the regulation of energy balance. Whereas up till there, he had been consuming about 3,000 kilocalories per meter squared. After they stopped paying him, his intake goes to pretty much zero, plus or minus a couple kilocalories per meter squared. And the amazing thing is his intake remains close to nothing for, that's 1, 2, 3, 4, 8, 10, 12 weeks, consuming very, very few calories. And you can see that his caloric intake then begins to pick back up when his body weight comes back down to about 75 kilos. So the point here is that at the end of this intervention, he weighs the same as he weighed beginning, and he's consuming the same number of calories. So clearly then the second component here is the regulation of appetite, or the regulation of drive to eat, which is completely suppressed in these individuals who've achieved positive energy balance. So if we surge ahead many tens of years to sort of a current model of how this system works, a very sort of oversimplified model, it's an endocrine feedback loop. And the fat mass is the regulated variable here in the bottom corner. Turns out there are a couple of hormones that we call adiposity negative feedback signals. Hormone that's made in the fat itself is a hormone called leptin, and the beta cell-derived hormone insulin, both are secreted and they circulate in the body in direct proportion to how much fat mass is present. They circulate, and they actually then find the central nervous system and find parts of the brain that are involved in regulating energy balance, ultimately changing appetite or drive to feed and changing energy expenditure. So for example, in this prisoner who was paid to overeat, his insulin and leptin levels would have been astronomically elevated. His spontaneous appetite or drive to feed went to 0, and his metabolic rate went from 1,500 to 3,000 kilocalories per meter squared. So this system, this sort of oversimplified system here, this model really works to understand and to ask questions and to test questions about the biology of body weight regulation. Just showing you a couple of interesting points here. This now is a cartoon of a rodent brain, and we do a lot of our basic work in rodents and then try to translate that work as quickly as possible into humans. But what you see here are a couple of coronal sections of a brain, and you have the cortex out here. This is the hippocampus and thalamus, and this thing that sits below the thalamus is the hypothalamus. This is where a lot of the action in terms of the regulation of energy expenditure and appetite happens. There's a bunch of groups of cells and nuclei in the hypothalamus that function together to coordinate how the brain responds to either energy deficit or to energy excess in regulating metabolic rate and regulating appetite or drive to feed. So what do we know about obesity and the way these two hormones work? We know that consuming a high-fat diet is one of the surest ways to make an animal or to make a human obese, and we take advantage of this in our studies of the physiology of obesity. So what you see here are some creatures that are now fed a low-fat diet or a high-fat diet, and you can see the animals consuming a high-fat diet become profoundly overweight and obese and do so fairly quickly on this high-fat diet. The hypothesis we have is that these hormones that are supposed to be regulating appetite and regulating energy balance in the setting of obesity no longer work, that the central nervous system has become resistant to the effects of insulin and leptin, and I'll just show you that here. So in these kind of experiments, what we can do in a rat, for example, is to place a cannula right down into the hypothalamus, that part of the brain that regulates appetite and energy expenditure. And in a low-fat fed rat, if we do that and we squirt just a little bit of insulin onto those cells in the hypothalamus, that will cause the animal to eat less, substantially less over the next 24 hours, consistent with the role of insulin as an adiposity negative feedback signal, as a signal that tells the brain to consume fewer calories over time. Whereas on a high-fat diet, a little bit of insulin does absolutely nothing. So just like we think about in type 2 diabetes in the muscle or in the liver, in type 2 diabetes and obesity, we have resistance to insulin in the brain and the central nervous system. And the same thing is true for leptin. A little bit of leptin straight onto those cells in the hypothalamus potently lowers food intake, but in animals fed a high-fat diet, there's resistance. There's no effect of leptin to lower food intake. So hormonal resistance is a common theme in metabolic diseases, in diabetes, and in obesity, and resistance to these hormones in multiple tissues, liver, muscle, adipose, and then in terms of the regulation of energy balance in the central nervous system. So this is sort of a model for what we think is going on, and many people think is going on in obesity. When we consume a certain type of a certain diet that doesn't have the highest quality macronutrients, that may have a lot of sugar, but that also is high in fat, you develop lipotoxicity in tissues, in muscle, in liver, and especially in brain. And when these toxic lipid intermediates accumulate inside a cell, they activate inflammatory pathways. And so inflammation in general is good when it's being used to perform immune functions, but when it's deranged and when it's being driven by overconsumption of, for example, a high-fat diet, this inflammation becomes maladaptive. And what that inflammation does is it causes these cells to no longer be responsive, to be able to respond appropriately to hormones like insulin and leptin. That permits positive energy balance to go unchecked, ultimately leading to obesity. And so here's just a sort of a proof of principle of this. We're able to then take these animals that have been fed a high-fat diet and infuse into their brain chemical inhibitors of those inflammatory pathways. So if you take a low-fat fed animal, and I haven't shown you this data, but in animals on a low-fat diet, there is no inflammation in the brain. Their brain is quite happy. And if you infuse an inhibitor of an inflammatory pathway in the brain of a low-fat fed animal, it doesn't do anything because inflammation hasn't been turned on and activated. On the other hand, in the brain of a high-fat fed rat, where there's inflammation leading to slightly positive energy balance over time, if you go ahead and block that inflammatory process with a chemical inhibitor of inflammation, you can see that you're able to profoundly lower food intake. Remembering that these animals are obese and their circulating leptin levels would be very high, by blocking the inflammatory pathway, you're now allowing those cells in the brain to respond to those high levels of leptin and turn down food intake. So this is the homeostatic regulation of feeding. This happens in parts of the brain like the hypothalamus and the hindbrain that are very primitive in nature, that are sort of reflexive in nature. These are the areas of the brain that we don't think about, like how you control heart rate and breathing rate. Turns out there's other parts of the brain that are involved in feeding behavior as well, especially as a human. Who had the chocolate croissant out there for breakfast? Anybody? Nobody's going to admit it, the butter and the chocolate. So the other problem that our patients have, especially as they become more and more overweight, is macronutrient preference changes. The most obesogenic substances in our diet are, as I've already alluded to, fat, but also sugar. And so the size of meals that some of our patients consume when we really get our dietitian in there probing intensely are enormous, the number of calories that can be consumed in a meal. And animals, the rats that I've been talking about, also model this as well. So you see from day -2 to 0, all of the animals are on a low-fat diet. When you switch them to a high-fat diet, look at that profound hyperphagic response. Animals, just like people, love fat. It tastes really good, and it is very rewarding. And so you can see that they consume a lot higher number of calories early, and even that persists on out over the course of time of consuming a high-fat diet. So what this speaks to is that feeding is a lot more complicated than I alluded to on that first cartoon slide, and we'll just skip over that. And it's even really more complicated than that second slide just shows. So this is just kind of focusing on the brain now, looking at some of the forces involved in feeding. And if you think about it, when you get up in the morning, thinking about breakfast, you know, you have to make a decision. It's morning, I have to get up, I need to coordinate motor movements, I need to go to the kitchen, I need to find some food, I need to cook it, I need to eat it. There are a lot of neurobiological factors involved: motivation, executive control. We have to remember how to work the oven or the microwave or the toaster. And then things that we are really interested in from a basic science perspective are things like liking and wanting. I really want that chocolate croissant, and when I get it, I really like it. And these are really hardwired, very potent neurobiological responses to our environment. This allows us to go out in our environment and find those foods that are particularly rewarding and particularly high in calories. So what this really begins to speak to, this cartoon now comes from a nice review article on addiction. What this really begins to speak to, and is increasingly recognized in our field, is that there's an overlap in the reward circuitry. So the reward circuitry, the nucleus accumbens and ventral tegmental area, are parts of the brain that are heavily implicated and involved in addiction and substance abuse. We now are beginning to recognize that parts of these parts of the brain also become hijacked in obesity and really reinforce these behaviors of folks to find and overconsume high-fat, high-sugary diets. And so I'll talk just for a minute on that. This is an interesting sort of an experiment in rodents again. And as I've already told you, that rats, creatures, humans, all of us, we really love a high-fat diet. So if you just treat these animals with a vehicle or nothing, you can see basically all they consume is fat. They love fat. But if you do that same paradigm I showed you before, where you put a catheter into the brain and infuse a little bit of insulin or a little bit of leptin, what you can see is that you completely eliminate that animal's preference for dietary fat. So what this begins to tell us is that these hormones, insulin and leptin, that act in the hypothalamus to regulate appetite and energy balance, also act in these reward circuits to control how rewarding, how much pleasure you get from a chocolate croissant, for example, so that you then don't overconsume these. And the hypothesis is that inflammation and insulin resistance in these parts of the brain eliminates the ability of these hormones to regulate this food preference, therefore driving overconsumption of a high-fat and high-sugar diet. And so I'll just show you a couple of basic science-y kind of figures in support of this, but what these data just show you in terms of those midbrain dopamine structures I just talked about, striatum and the substantia nigra, animals on a high-fat diet have insulin resistance there too. These are just measuring one of the enzyme systems in the brain that insulin turns on when these neurons see it, and you can see that on a high-fat diet, these responses are very blunted. So there's insulin resistance in that part of the brain. And so this is how insulin works when it hits a cell. This is the insulin receptor, and there's a whole cascade of sort of biochemical and cellular events that have to happen in order for insulin to work. And what we did in this particular experiment was we took one of these, and we actually have the gene for this thing called insulin receptor substrate. We package it into a little adenovirus, and we're able to do gene therapy in these rats. If we microinject these little viruses, they get into the cells, into the neurons in that part of the brain, overexpressing this IRS molecule and turning insulin signaling back on specifically in that part of the brain. So can we experimentally prove that these parts of the brain are important for high-fat diet, hyperphagia, and for overconsumption of rewarding foods? So that's what this shows. Again, on a high-fat diet, that insulin signaling pathway is greatly turned down. But if we put back into the brain that IRS molecule, we can turn it back on, turn it back up to normal, a little bit more than normal. And what happens to the animals? So these are the animals that have insulin resistance in those dopamine areas of the brain. They overconsume a high-fat diet. When we put that molecule back into the brain, we can turn the consumption of specifically of that high-fat diet back down to the number of calories, very close to the number of calories that the low-fat fed animals are eating. So we think that this idea has a lot of merit and has a lot of interest right now. And in fact, an extension of this idea is what I have to go finish this grant up on today after I do this talk. So really, what we're beginning to realize is that reward and or areas in the brain and targets that have been classically sort of thought of as addiction targets in the central nervous system are increasingly important in metabolic disease, in diabetes and obesity. So, as I said, when I see patients who've historically been reasonably well controlled and then they come in with horrible control of whatever chronic disease they have, it's the top 4 or 5 on the differential diagnosis is depression and more depression. And the interesting thing is that in our obese subjects, in particular, these folks do not respond very well to typical standard depression therapies, and even fairly intense therapies don't seem to work. So as usual, I'm obsessing over this, and then I've learned some interesting things by reading just enough to become dangerous and go back to the laboratory. The exact same models we've been talking about, the rats, the low and the high-fat diet, and it turns out there's a really well-validated way to measure how happy a rat is. You put him on a little leather couch and you talk to him about his childhood. Either that or you actually put him in a bucket of water. And so a happy rat will just happily swim around in the water, and a depressed rat will swim around for a little while and then will just float. So this is an assay called learned helplessness or hopelessness, and it's a very well-validated assay for human therapeutics. So any antidepressant drugs that have efficacy in humans will have efficacy in this rodent assay of depression. So what I think is absolutely fascinating, and I don't even show you the 60% fat diet here, but in a dietary fat dose and time-dependent manner, rats will become depressed on a high-fat diet. And on the 60% fat diet, it's more severe and it even happens more quickly. Just to confirm with you that this is relevant to what we're talking about, these animals on a high-fat diet are also significantly glucose intolerant. This is an obesity, diabetes, or diabesity phenotype in the animals, and they have concomitant depression. So the other interesting thing is when we throw stress into the mixture here, and who in this modern environment isn't experiencing some level of stress in their life on a day-to-day basis. Turns out that the forced swim test is an assay for depression, but it's also a brief, stressful event for the animal. And so I'm showing you here the food intake data of these animals, and after the red arrows indicate times when they've undergone the forced swim test. And what you can see is that after every subsequent stressful event after they do the forced swim, this little spike in hyperphagia gets bigger and bigger and bigger and bigger. Almost, I don't know, if you squint, almost looking a little bit like rat binge eating syndrome, I don't know, binge eating disorder, but it's really fascinating. And this looks an awful lot like escalating substance abuse in rodent substance abuse paradigms as well. So the low-fat fed animals are down here, right? They've undergone the forced swim test, but they don't change their food intake. So the stress, presumably they experience the same degree of stress in the forced swim test assay, but they're able to adapt to that stress, and they don't change their feeding behavior. They don't become hyperphagic. They don't have the same sort of escalating hyperphagic responses that the depressed high-fat animals have. So I don't really know ultimately what this means in the long term for my humans, but I suspect it's really quite important, and that stress and depression are really potently synergized in terms of impairing self-care behaviors and chronic disease. So this is basically all I know about serotonin. I just thought I'd put this up here to point out to you that serotonin is all over the brain too. And it's all over, it really overlaps with those dopamine circuits we talked about in terms of addiction and reward and pleasure. And of course, serotonin is heavily implicated in feeding behavior. A lot of our prior weight loss drugs that we've had on the market and then have come off of the market, largely related to mood issues, have targeted the serotonin system. But let's talk about serotonin and obesity and inflammation, and so this really reflects some interesting work we tried to get done with Rick Shelton, who was previously here at Vanderbilt, who I think many of you probably know. So this really brings together this intersection of a high-fat diet and inflammation, and what I think is a unique phenotype, and that is obesity-specific depression. So the model here, I've shown you that when you feed rats a high-fat diet, you activate inflammatory signaling pathways. And what this does, this inflammation activates a number of enzyme systems in the brain that function essentially to siphon the precursor for serotonin synthesis, which is tryptophan. So normally tryptophan would go down this pathway and be used to synthesize serotonin, and of course serotonin is also quite important for regulation of mood. When you have inflammation and you turn on these particular enzymes, you siphon tryptophan away from serotonin synthesis and cause the synthesis of these intermediates, which are conceptually analogous to the lipotoxic compounds I talked about on a high-fat diet. So kynurenine, kynureninic acid, and quinolinic acid are very toxic to cells in these circuits. They will actually reduce dopamine and dopamine synthesis. They'll injure these cells and cause neurotoxicity. And so if you think about one of the mainstays of therapy for depression, in particular SSRIs, and then if you think about obesity as a state of perhaps relative serotonin depletion, you begin to understand data that look like this. And so Rick pointed this out to me, and this is absolutely fascinating and is absolutely consistent with what we see, at least in my practice, and that is that people who are obese and depressed don't respond to typical therapy. So they're showing here the change in this depression score in normal weight individuals versus overweight individuals, and then in obese individuals, and there's a very, very strong sort of BMI-dependent impairment in response to depression therapy and obesity. Think about it, and if we think Rick's model has any merit, it makes perfectly good sense, because what is an SSRI going to inhibit the uptake of if there's reduced amount of serotonin being released or even synthesized from the synapse. So I think this is fascinating, and I don't know where this will lead our basic science program, but if you all have any ideas, I'd be glad to hear about them. We, with Rick, have gone into we have a number of human cohorts that we study, really translating a lot of the ideas that we've been talking about. And to me, these data really cement in my mind the fact that obesity, depression, is a very unique and different beast than non-obese depression or obesity itself. And so I'm just showing you here a few inflammatory cytokine levels, and what you see is that in non-obese individuals, if you're depressed, you have an increase in the circulating levels of interferon gamma. It goes from 3 to 6. We know that obesity itself is a state of mild chronic inflammation, and so if you're obese, you go from a level of 3 to 6. But the interesting thing is, to me, is just fascinating. If you're obese and depressed, the levels of these cytokines go up a log, tenfold, up to 85. And this is true across a bunch of these different cytokine levels, and even C-reactive protein, which is sort of an index of whole body inflammatory burden. So I do think that depression in obesity is a fundamentally unique phenotype, and we're hoping to begin to develop more basic science models to begin to try to understand why this may be the case. But if we come back to our friendly and now happy rats, put them on a high-fat diet and ask them to swim, remember this is the effect of a high-fat diet in a rat to reduce swimming time to cause them to become depressed. But if we do the exact same paradigm here, but instead pre-treat these animals with that same chemical inhibitor of inflammation that I talked about at the beginning, they swim much more, they become much happier, swimming around in a little bucket of water. So I do think inflammation, CNS inflammation, is a depression target, at least in preclinical models. And there is some early phase work, I think, going on looking at anti-inflammatories in depression. So in terms of this model, in this high-fat diet feeding, lipotoxicity, inflammatory signaling, what I've shown you so far is that sort of food intake and mood, I think, in preclinical models, there's pretty strong evidence that we can modulate those responses. But I wanted to talk for just a minute, was asked to talk just a little bit about this. Is it just the fat? So of course, as a macronutrient, fat is more dense than carbohydrate or protein, but fat is also informational. And so what I'm just showing you here is the structures of 18-carbon fatty acids. Starting at the top is a saturated fatty acid, that's stearate, and then you introduce a single double bond. You get now a slightly different three-dimensional structure in oleic acid, linoleic, and the polyunsaturated alpha-linoleic acid. So you could envision in your mind, in terms of metabolism and in terms of how these fats interact with cells and molecular targets in cells, that they might have very different metabolic effects. And in point of fact, that's very true. It's very well recognized that the degree of fat saturation in the diet is an important predictor of metabolic dysfunction. In particular, the 16-carbon saturated fatty acid called palmitate is horrible. We do a lot of experiments in the lab with palmitate, and if we take a dish of neurons in a culture dish and just show them a little vial of palmitate, they immediately die and go away. So palmitate itself is very, very toxic, and is toxic to neurons in particular. And so I'm showing you here rats that are fed the palmitate-enriched high-fat diet on the top. The low-fat fed rats are shown here, and these guys got fed a diet that is enriched in the monounsaturated fatty acid, oleic acid. So where do we get oleic acid in our diet? Does anybody know? What is it? What is it if you live in Italy? It's olive oil, right? So oleic acid is a major constituent in what you might call the Mediterranean diet. And it looks like olive oil, at the same caloric density as lard, is much less obesogenic. If we look at the brain then and ask, well, so here's total weight gain. You can see that weight gain is elevated on the palmitate enriched, no different on the oleic acid. Fat is a little bit intermediate with oleic acid. And then food intake is not the same as the low-fat diet, but it's not as high as the high-fat diet either. And so what this begins to suggest is that oleic acid consumption, independent of lowering fat intake, may be protective. And if we look in the brains of these animals at some of these markers that are thought to be readouts of the inflammation and cellular dysfunction in terms of endoplasmic reticulum stress and oxidant stress, these are the things that cause neurons to die and not function. And you can see here that palmitate is really good at activating ER stress and oxidant stress in neurons. But when these animals are eating almost the same amount of oleic acid-enriched diet, you don't get the ER stress, you don't get the oxidant stress happening. So it speaks to the idea that all fats are not created equal, that saturated fat in particular is particularly inflammatory, and I just show you that here with the effects of that on IL-6 expression in the brain. The saturated fat diet really ramps it up a lot, and the monounsaturated fat diet dials it back quite a bit. So what about saturation and depression? I'm not an expert here. Rick Shelton and I have written, I was mentioning to some of you before, a number of grants to begin to look at this in a clinical setting, and we just could not get reviewers to buy into this at that point in time. But there is a smattering of literature on this. I was unable to localize. I know there are a couple of randomized controlled trials going on, and I had thought that a couple of these had been published by now, but I wasn't able to find those in my spare time I had this last week. But there is an increasing literature on this concept, and here I'm just showing you sort of a meta-analysis of 22 epidemiological studies. And a number of these papers seem to be consistent, and that is that the risk for depression in populations of people adhering to a Mediterranean type of a diet with higher monounsaturated fat consumption have a reduced relative risk for the development of depression. So hopefully this is something you all are going to talk more about this morning. I think it's really interesting and has a lot of potential translational and therapeutic potential. So let me just finish up with another really interesting thing that we experience clinically, and I don't know why this is, because when I get home by 8 or 9 o'clock, I'm totally beat and I'm ready to go to bed. My patients who are obese and diabetic and metabolically a mess, for whatever reason, stay up till 2 or 3 o'clock in the morning and sleep till 2 or 3 or 4 o'clock in the afternoon, and I, for the life of me, can't figure it out. Until I had a junior faculty member join our laboratory, and it turns out dietary fat's the culprit here too, maybe. So I'm showing you here, now this is sort of a circadian way to look at data, and what this box shows you here is the lights on. So this is daytime for a mouse, this is nighttime for a mouse. What you have to remember is that mice are nocturnal. So night is day for them and day is night. Now, if I have you all really seriously confused. But a mouse on a low-fat diet eats their meals, eats their food during what would be their day, during their active period. So you can see here, these first 3 lines of these data, you can see that the mice are sleeping when they're supposed to be sleeping and are awake when they're supposed to be awake. And these little red stars indicate the time when we then switch these mice to put them on a high-fat diet. And what you can see is that after they start consuming the high-fat diet, now they're eating during what is their day, they're also eating during what is their night. They're basically eating around the clock, 24/7. Very, very, very typical of my patients, unfortunately. The data shown on this side is just another way to demonstrate this. And so this is sort of the 24-hour clock. So from 0 to 12 would be the lights on, 12 back to 0 is the lights off. And you can see on a low-fat diet, animals are having these feeding bouts during what should be their day. When you put them on a high-fat diet, now these feeding bouts happen essentially around the clock. So a high-fat diet clearly alters circadian organization, clearly alters in our patients their sleep-wake cycles pretty profoundly. And we're beginning to understand that has a very profound effect on metabolism, but also has a profound effect on neuropsychiatric function and mood and a bunch of other things. And so this is something I've been interested in for a little while as well, and I don't know that this is really well established or accepted in the psychiatric field, but there's this thing that's been described by a particular group called night eating syndrome. And these are people who wake up in the morning really anorexic, not hungry, don't consume much of anything. And then starting sort of mid-afternoon, they have this real profound hyperphagic drive. They tend to consume a lot of carbohydrate, they tend to consume a lot of fat, and they end up consuming the vast majority of their calories after their evening meal and well into the wee hours of the morning. Really interesting phenotype. The interesting thing is sertraline appears to be pretty efficacious in treating this night eating syndrome. So you can see here a randomized controlled trial of sertraline in terms of this night or this night eating scale here improves significantly, and weight change rather substantially reduces on treatment with sertraline. So we're really interested in this as well. Is there an interaction of serotonergic circuits, of dopaminergic circuits with circadian organization that then begins to pull together mood, that then begins to pull together meal patterning, and then begins to pull together sort of resynchronizing energy balance regulation and energy homeostasis. So that was my last little tidbit. These are the names of a lot of folks who have worked on a lot of this over time, in particular Rick Shelton and the depression work that I've been talking about. We have been translating a lot of these concepts and ideas into human cohorts now. We're studying a very large obese diabetic cohort with a lot of sort of psychometric testing, neuropsychiatric function, a lot of functional MRI and brain imaging methodologies, as well as metabolic function testing. And so hopefully, maybe in a year or so, I'll be able to tell you how much of this actually translates to humans with obesity and diabetes. So I'll stop there and be happy to entertain any questions you all might have. And thank you very much for having me and for your attention.